Uh, Hello, Professor Salvatore. Thank you very much for coming to our podcast.
Pleasure. Thanks
Yeah.
for inviting me.
I think it was a little bit of a long trip coming to Japan,
Yes,
right?
yes. It was very good experience to come for. This is my first time in Japan,
Oh.
so it's good to visit this beautiful country, the culture of this country. I'm quite passionate about samurai culture, so it's good to be in the land of samurai, and appreciate it. I really appreciate it.
The weather is not the best nowadays, though.
The weather is hot everywhere, even in Spain and in Italy. So it's not. I mean, it's quite hot, but we are from Mediterranean, so we are used with that.
Yes, yeah, it's not that difficult for us.
Yes.
Right? Professor, you're a professor at CEU Cardenal Herrera, and you have also other positions. You're a part of the review member board of review for several internationally known papers. But I usually ask my guests to introduce themselves. So could you talk a little bit about yourself?
Yeah,
Instead of
yeah.
just mentioning a CV.
Yeah. I think it's easier. It's always complicated. I understand. When we have guests and you have to introduce a guest with big curriculum. Sometimes it's like, okay, this is Professor. I don't know, Salvatore. You do your you do your introduction. So yeah, I'm basically now I'm located in Spain, in Valencia, as a professor of biomaterials, dental biomaterials, and minimal invasive dentistry, CEU Cardenal Herrera in Valencia. I've got other visiting professorship at University of Napoli in Italy, Federico II. I'm also honorary professor at King's College London, where I did my PhD, postdoc. Spent almost 9 years in London working at King's. And I also have some other position in other university like Hong Kong. So I'm honorary professor at Hong Kong University. Russia, Moscow University, Sechenov. And then these are the main one. So and then that's my position. I'm now in Valencia, stable since 2012, and that is the place where I do all my teaching activity and research activity, because I'm a professor. I have to teach undergraduate and postgraduate student, but I still consider myself a researcher. So I like to spend as much as possible my time in the laboratory. So I'm PI, principal investigator of a group of research, which is about bioactivity and regeneration of heart tissue. So that's more or less the name of my group. So I want to stay in the lab and try to control all the experiments and the project. So yeah, that's more or less what I do in Valencia.
So have you always been interested in research?
Yes.
When did that start?
Well, that started like a game. My story, my journey through the dental research is quite fun, because I was very young. I was 16 when I basically decided to start thinking about something dental, because my cousin, my old cousin, is basically dental technician, and I was just a young guy going around his laboratory. I was watching him creating denture, and I got like, this job is very nice. So, and that was my first title, my first school. So I studied dental technician, because in Italy we studied it as a college, sort of secondary school. So I did 5-year dental technician diploma, and I got the diploma, start working as a dental technician, and then the people that I'm working with, they were like, "Oh no, you should carry on. You should do dentistry." And I said, "Okay, why not?" So I applied for the university, and before applying for the dental school, I studied as a dental hygienist. because in
Also?
Italy, you have to be accepted to be a dentist. You have to take an exam. So I did 2 exams in that year, and I did dentistry and
Dental hygiene.
dental hygienist. And then the first one that I got accepted was dental hygienist. So I did 3 years dental hygienist. I worked as a dental hygienist, and then I kept moving on. And actually, when I was dental hygienist studying at the university, I met some professor at the University of Bologna, and they asked me if I wanted to do some research. And they say, all right, say, why not? I would like to do some research. And, start doing a bit of research as a game. I didn't have an idea to become a researcher. I was thinking about dental hygiene and then getting a dental degree, working in an office, having my dental office, my patients. And actually, it didn't go like that, because actually when I start playing like a researcher, there was actually the Bologna University. There was a bursary, a sort of grant that supported students to go outside the country, to go, wherever you want in Europe, and doing for research. So I said, you know what, I'm gonna take it. So I went 6 months in London to do my thesis, my undergraduate thesis in research. Went to London, King's College, and then was the period when I basically fall in love with the research. The reason why I went to London, when I got this possibility, they gave me something like 3,000 euros to go in there and to do research, write your thesis, go back, graduate, and that's it. And I said, you know what, I'm going to go to London. I'm going to enjoy London by night. I'm going to go to disco. I'm going to have fun. I was really young, so I didn't have any idea about research. So I said, it was just an excuse to go to London and enjoy London.
Fun, yeah.
And then I went to London. I entered the lab, and I don't know what happened to me. I didn't go out of the lab. I didn't go any disco. I didn't do anything. I spent 3 months inside the laboratory doing research, non-stop. So I was so in love I was so attracted by research that when I went back to Italy, I say to my professor, I say, okay, I don't want to be a clinician anymore. I want to be a researcher. And at that point in Italy, we did not have so many opportunities. My professor, they say, oh, here it's difficult. So I just contacted London and say, look, can I go back to London and work with you? And they said, yes, come, you are very welcome. We're going to give you a PhD. We're going to give you all the possibility to study and finish your career. And then at a certain point, between being a dentist or an academician, a researcher, I preferred, I choose research. So, and then I said, okay, I'm not gonna take any clinical work. I'm gonna dedicate myself to academia, to become professor and to do research and to work as a researcher. And that was the situation. So it was not planned. It was just sort of, okay, going to London, and I'm gonna enjoy the nightlife. I'm gonna enjoy the London city, but actually my life changed completely. So from that moment, I didn't stop anymore doing research. Then I went to USA, working with David Pashley, Franklin Tay, then collaborating with many other researchers around the world, Canada, Brazil, a lot of friends in Brazil, a lot of research in Brazil. And that was the situation. Now, there we go. I'm almost 50. Still playing with research, still enjoying the research field, and there is nothing better for me to do. I mean, I still like it, still really like it.
And I'm glad you still do, because I saw your lecture today, and it was very, very interesting.
Thanks.
You shared very interesting information today.
Thanks.
So what happened? Like you're now based in Spain, in beautiful Valencia, right? Mm-hmm. What happened? How did you move to Valencia over there?
Yeah, I mean, I was in London. I was working in London. I was growing up level by level. PhD, postdoc, research associate, And then there was a moment that, I was supposed to jump to the first level of, it's called in UK, it's called lecturer, right? So you have lecturer, then become senior lecturer, readers, professors, and that's it. Then you retire. So I was about to move from, junior to some, lecturer position. But actually, in that period, there was a big change at King's College. So, change of the dean, change of the head of the department. So, a lot of political changes, political extra research, extra academia situation that sometimes they push you out, or they push you to take another route, And actually, in that period, I was starting collaborating. Actually, I was already collaborating with Granada University in Spain with Professor Manuel Toledano and Raquel Osorio. I was already working with them for 2 years and doing a lot of research. So I was traveling a lot from London to Granada the last few years of my life in London, and Manuel Toledano, Professor Toledano, he was like, "Sorry, you should come to Spain. You should live in Spain. You are Mediterranean. You are Italian. You will be much better here in Spain than London." But I was so used to live in London, to work in London. King's College, big university, was not actually considering the offer. But then, when there was this situation, this political situation at King's, right? Then I was like, I think I need to start thinking about moving out of this school, because that would cause me a delay in my career, Yeah. And then I talked to Professor Toledano. I said, "Man, maybe you're right. I should choose something here in Spain. Maybe I should consider Spain as my next step." And he said, "With your curriculum, you can choose any university you want in Spain." And I said, any place by the sea, because I want to be by the sea. Yeah. And Manuel Toledano said, there is a very nice university in Valencia, and they are looking people like you, with your curriculum, with your research activity. So, we say, okay, so I'll send my curriculum, and let's see what happens. And in less than 1 week, they gave me a contract. So I sent the curriculum, they replied me after 3 days, and after 7 days, I had already signed the contract with them. So we moved to Valencia, me, my wife, I already had a son. And, the first 2 years were a bit difficult for me, because I need to adapt myself to Spain rather than UK, because it's different system. And I was used to work and live in a huge city, with a different system. So the first 2 years, they've been a sort of adaptation. And then after these 2 years, I realized that it was the best thing that could happen to me, because it changed my life in a good way. Nice. So very good position, salary is not bad. They promised me to give me a laboratory, and they maintained the promise. And I think I have a very nice laboratory now. So, and with my group, with my students, my people, living in a sunny city, good fish, good food, good weather. So, and my family is happy. My wife is happy, so that's important.
That's the most important.
Yes, the most important, because when wife is happy, life is easy.
Yeah.
And that's probably something that I also learned from.
To keep in mind.
Yes, I keep in mind, because if the wife is not happy, life could be tough.
Yeah.
So yeah, that's the situation.
Oh, nice. Can you talk to us? You said you have your laboratory. What type of? I've heard, but can you share with us? The type of research that you're doing in your lab.
Yeah, as I was saying before during the presentation, my background started. My first topic in addition, in research, was preventive dentistry, because, as I said, I'm also a dental hygienist. So he started with prevention, and then he evolved to adhesive dentistry, prosthodontic, because I'm dental technician as well, dentistry. So I started working on adhesives. Okay, so there was in that period we had new generation adhesive. The 7th generation adhesive, simplified adhesive. They had a lot of problem of stability. They degraded very quickly. So we were trying to understand what was going on with this system, why they were not performing so well. And so we started analyzing the interface, the degradation, try to understand what type of degradation was occurring at the hybrid layer. In that period, I met many important people. Dr. Sano from Sapporo University, for nano leakage. David Pashley, probably one of the best teachers that I've had in my life. Franklin Tay, Riccardo Carvalho, and then Lorenzo Breschi. And we were all working together in order to understand, addition. Understand why this interface was not living so long, And then in a certain point we understood most of this degradation process, and then we started thinking about, okay, how can we improve it, right? What should we do? So different groups, people working on chlorhexidine, people working on multi-step system, people working on multi-layer application of adhesive in order to get something more long-lasting. But in my case, in that period, I was working on preventive dentistry. I was working with abrasion with bioglass, bioactive glass, which are a very strong remineralizing material. And on the other side, I was working with adhesion field, and I went to Augusta, collaborating with David Pashley and Franklin Tay. And they were working on remineralization of the interface using biomimetic strategy. And then, I was like, oh, that's very interesting topic. So I can go this way, and I can apply the concept of remineralization to hybrid layer,
yes.
Protection, repairing, stabilization. So in that moment, I start playing with some bioactive filler, remineralization filler, try to make, to modify this resin-based material and dope this material with bioactive glass, up to now that I've developed some calcium phosphate fillers. So I'm not using bioactive glass anymore. So I'm actually now using some fluoride doped calcium phosphate that I've created in my lab. I've also patented them. And this filler, they can be placed in this flowable composite, adhesive, composite, cements, and they can actually deliver ions, and they can basically protect, remineralize, and repair the interface in case of problematics. Okay.
And talking about problematics, deep caries are one of the biggest problems that we have. A couple of weeks ago, last week, Professor Hall Duncan was here, and he was sharing his insight on when there is exposure or something. So because he's an endodontist, on your side, when there is deep caries, like how do you manage it? How do you recommend people to manage it? And what's the role of these materials in these kinds of cases?
That's part of my research, actually. I mean, one side of my research is to make this bioactive material to protect the interface and repair the interface, stabilize the bonding. But from the other side, another aspect of my research is to make resin-based material for indirect pulpal capping, after selective caries removal. So as I said before, I also teach minimal invasive dentistry, and one of the procedures that we use in minimal invasive dentistry is selectively removing the caries, which means remove the most degraded, infected layer of dentin, so the dentin that cannot be remineralized because it's completely denaturated, completely degraded, and leave that part of dentin which is partially demineralized. And that part of dentin is still okay, the collagen is sound, so they can be remineralized. So just to answer your question, I am very close to the mentality, to the philosophy of King's College London, because when I left London, the group of Avi Banerjee, Timothy Watson, they were actually working on selective caries removal and avoid to expose the pulp. So that means you have a very huge caries very close to the pulp. Sometimes you look at X-ray and say, oh, that's good. This is, Francesco Mannocci, also the head of the endodontics department. So I'm basically following the same philosophy. So if the tooth is still alive and there is no apical lesion, right? So you take your vitality test, tooth is alive, you take sometimes you can take a combine examination, no apical, not very, evident apical reaction. All right, so in that case, it would be good to give a possibility to the tooth. All right, say, okay, you know what? I'm going to do my selective caries removal. I'm going to try to not expose the pulp if I can. But even if I expose the pulp, I will try to apply this, bioactive material and give a chance, to give a possibility for the tooth to react and to defend. Because tooth is alive, pulp is a living tissue, and it has regenerative. It has an immune system. It can repair. Yeah. All right, so we should give a possibility. Some other people, they think, oh no, the bacteria they're infected. The pulp is gonna die. No. I don't think so. Mm-hmm. I think the pulp can actually react. They can fight. We just need to help the pulp to fight. Mm-hmm. So the idea is to do selective caries removal. Try to not expose the pulp. So leave some tissue, some caries there. No problem. Leave it there. Sometimes you excavating and it starts bleeding. If you can stop the bleeding, you can do your pulpal capping. And then place the role of this new material is really important, mm-hmm. because these new materials, they can actually stimulate the pulp to produce, to repair. So with this ion releasing, they can basically stimulate the pulpal cells, the stem pulpal cells to differentiate, to migrate to the lesion, produce reparative dentin. Okay, and after there are a couple of studies very interesting published, even more than a couple of papers published by Mannocci, Timothy Watson, Avi Banerjee, and which they show that there's actually you have about 65% possibility to save the tooth, right? So that is, using this material, you can basically stimulate the pulp to regenerate, to produce this reparative dentin, and you keep it there, sort of stepwise technique. You place your regenerative material there, your bioactive material, leave it there. You follow up the patients if you don't have any big reaction. Sometimes if the pulp sometimes it can happen, pulp die, all right, so that's fine. We remove everything, we do endodontics, that's it. But if you keep it there and after 1 month you take the vitality test, you take X-ray, and you see that the tooth is safe, you're done. You save the tooth without any endodontics treatment. You can basically do some stepwise med technique. You can basically remove part of this. Usually nowadays the material that we use the most is MTA, calcium silicate. So you can actually remove part of the calcium silicate. You can replace it with a fresh one. You can do a sandwich technique. You can place on the top GIC, or you can place, some people they like composite. You can do a partial stepwise or total stepwise technique. And it seems to work. So that's my opinion. So if you can save the tooth, we should do the best we can to save the tooth before endo. When it's completely hopeless and the tooth is, you see the lesion on the apical part of the roots and the tooth is not alive anymore, no way. Just go for endo. But if there is at least one possibility to save the tooth, just do it. And the rule of this material, of this bioactive material, new generation material, it's absolutely important because it's depend on material. It actually depends on material. And if we have material with much more biocompatibility, with much more, how can I say, stimulating effect, this material that they can release some ions or some components that they can actually boost the pulp to react, material that they have also antibacterial properties, which can, since when we do selective carious removal, we live in bacterial there. So it's good to have a material that they can actually kill bacteria. So yeah, that's the idea. That's the.
I heard also like some opinions that, like you mentioned, it's fine to leave some bacteria there, and it's fine because you're isolating the bacteria.
Yeah,
As long as
exactly.
you're doing very good isolation, then it should be safe, right?
Yes, that's the concept. I mean, there are some people, I'm not gonna name them. I don't want to get in trouble with these people, but there are some endodontists that they are absolutely against this philosophy. They say, oh no, you leave bacteria there. Those bacteria, they're gonna cause destruction. They're gonna cause a problem. But actually, as you said, it's not like that, because if you seal this bacterial, if you close the cavity with this material with strong antibacterial effect, there is no way that the bacteria can do anything wrong.
Because they can't grow, right?
No.
There is nothing to feed on, right?
No, they can go everywhere, because actually they get inhibited, they get killed by the material. And remember that the pulp is a living tissue. Pulp fights. Pulp has an immune system, and it has a very strong ability to repair them itself, and to repair also the hard tissue. So I think, as I said before, we need material that can help the pulp to repair themselves, the situation. And that's what it does. I mean, when we got the caries, when we do caries removal, actually we always bond on sclerotic dentin, because as soon as we get invasion of the dentin with bacteria, the pulp realize that the caries is invading the dentin, and the pulp start mineralizing the tooth. That sclerotic dentin is just a mechanism of defense of the dentin. So the pulp is ready, is keen to defend the tooth. So that's what we need to do. Yeah. We need to help the pulp to defend themselves.
Okay. One more question
regarding
this issue.
Yeah.
So you mentioned like selective caries removal.
Mm-hmm.
There are many tests that are done to kind of identify which parts to remove. The luminosity test, the stains.
Yeah. Good question.
Like that. In your opinion, is it always best to kind of check by yourself, like the tactile sensation and how it's being removed, or like how do we identify what to remove and what to leave?
That's the big question.
Sorry to put you on the
spot. No. I mean, that's actually the answer. The research needs to answer this question, because now what we as you say, we have some chemiomechanical methods that can be more or less selective in terms of removal. If we think about enzymatic selective carious removal system, they can degrade the infected dentin. They can basically deactivate when they emit the sound collagen. So you don't need to actually excavate. You just need to collect what the chemiomechanical agent has dissolved, which works quite well. We have very good system now, but we can also get the help of some instruments. For example, we can have we can base our decision, and say, okay, now we need to stop. So how much caries we should remove, how much caries we should leave. We have a potent tool, which is fluorescence. So we can work with this new generation system based on fluorescence, laser fluorescence, or UV fluorescence, and using this different wavelength, we can identify sound tissue and discriminate the sound affected and infected. So you keep excavating, until the visual fluorescence signal is going to tell you, done, you done, stop. You have removed all the bacteria. You have removed most of the quercetin, right? So you can stop. So I think in the future, it would be a combination between chemiomechanical agents plus these. I'm not gonna name any company or any product, but there are several good fluorescence or light system to discriminate, to identify infected from affected, and there are very good people working on this field. I've got a very good friend of mine, Hervé Tasserie, from the University of Marseille and Montpellier. He's got a very great experience with this type of systems for carrier identification and carrier removal. And it's absolutely... The problem is that we don't teach these things in university, right? So there are very few people around the world teaching this mentality. And it's a philosophy, this type of dental philosophy, dental procedures to students. So most of the schools, they are based on total removal, adhesives, composite, and that's it. So we should focus, we should push more and try to make the minimal invasive intervention dentistry
more common.
Yes. for our student, because if you don't teach it at the university, you will not be prepared. Will not have when you listen to us talking about this, most of the students, they say, "Oh no, I've never heard about that. I don't want to change my protocols."
Yeah.
So I think schools, they need to implement. They need to have much more minimal invasive philosophy in terms of cardiology and conservative dentistry.
And speaking of minimal invasive dentistry, like glass ionomers or like bioactive materials, for example, are kind of the way to implement in this kind of concept, because they kind of help the tooth, kind of repair or like remineralize, right? In your opinion, what is the direction that these materials are going in? Like, how do you choose to say that this is material that is bioactive? And
yeah, I understand what you mean. Yes, as I said before during the presentation, there is a bit of speculation on bioactive in dentistry is still a buzzword. We are not all agree on bioactivity in dentistry, so we still need to find a general compromise on the dental bioactivity or dental biomaterials, bioactive materials. But as I said before, there is also some speculation on the other side. So nowadays, all the material able to release some kind of ions, they can be classified as biomaterials. I don't agree with that. Actually, I think, as I said before, the minimal requirement for a material to be classified bioactive, and probably is my opinion, but I think is not actually by my opinion. Is based on the concept of previously publication of other authors. If we think about Professor Hench, and bioactive material is a material that, when in contact with body fluid, is able to induce precipitation and formation of apatite. So at least we should maintain this concept for bioactive material. So in my opinion, bioactive material, they are those type of material able to release ions, and these ions can basically reprecipitate in form of apatite, apatite-like minerals. So all the other material that they release ions, they are ion-releasing material, but should not be considered bioactive, because even if we talk about calcium silicate, calcium silicate, they rarely induce precipitation of apatite unless they are placed in some specific in vitro condition. So yeah, we want to define this material bioactive. I don't know. But as I say, there's a minimum requirement. This material, this new generation material, which we call bioactive, the minimum requirement should be a material that's placed in simulated body fluid, artificial saliva, are able to produce at least some kind of apatite precipitation. Then if they have antibacterial properties, if they have osteogenic, osteoinductive properties, that's fine, even better. But as a minimum requirement, we need to be able now to discriminate, to divide classic ion-releasing material from bioactive material. Because now in my opinion, there is too much speculation. So every company, every people, that they make their own, even GIC. GIC, that we say that is basically the father of the dental bioactive material, they are actually not bioactive material because they don't produce any apatite unless they are placed in some specific condition, some in vitro condition. So again, bioactive material, minimal requirement, production of apatite deposition. And then all the other material they are ion releasing material that they can be used in minimal invasive dentistry, in selective caries removal. Absolutely fantastic material. And I like this material. I've been using this material since the beginning. So absolutely nothing against this material. But we should divide ion releasing from bioactive material.
Okay. One more question and
okay. Yes.
And we're talking about some futuristic thing and your image, how do you imagine this thing is going to happen? So biomaterials or like ion releasing materials, they're usually, they have ions inside them and then they're left, for example, in the cavity. They release these ions, but they deplete over time.
Yes.
Right? So there are some, products that mention recharging these restorations. But even when we're talking about recharging, for example, like sometimes secondary caries happen, right? Some bacteria leak into these kinds of cavities.
Yes.
So do you think that would be a way to kind of delay this process enough that it can actually release on demand? Or like Professor Imazato from Osaka University calls them smart bioactive materials.
Smart material.
Yes. How far do you see are we from achieving something that is this kind of
I think
a switch in?
Yeah, we need a bit of more time. We need, as I said before, we have to convince the company like GC and other companies to invest more on this type of material, on this type of philosophy. We need to change the mentality of many teachers and professors and schools to believe in this type of clinical procedures and this type of materials, clinical procedure plus this material. We need a lot of work in order to make our bioactive material more precise and more specific. As you said, they're going to release ions, but in a certain point, these ions, they're going to
deplete. Yeah.
Deplete, is gone, they're not gonna work anymore. We don't know about that yet. So, but for sure we can create with some technology, some smart technology, in order to have this releasing of ion on demand. So basically, if there is, we can get that in vitro. We have this result in vitro. What we don't know is how long they're gonna last. Okay, so we know that these material, they get activated only when there are bacterial, or only when there is leakage, right? And from my point of view, I've developed this fluoride-doped calcium phosphate. From my point of view, I'm not like I want to have this releasing continuously. I want to have this releasing of ions when basically bacteria enter inside and fluid enter inside, and the material is going to produce a mineral that is so strong that you don't need to have any more activity in the future, because actually you are precipitating some sort of fluoroapatite or some other components in the future, I don't know, that actually they are so hard that bacteria cannot actually penetrate, they cannot actually go inside. So it's not something that is going to stay there forever. It's something that is going to get activated, it's going to produce some sort of super dentin, super mineral, okay, or super components that actually makes the life of bacterial very miserable, so that they can actually go in, you know, because you are creating an environment that for them is not okay. So the objective is not having something forever. It's to obtain a ceiling that is so long that actually our restoration, they can stay there something like, who knows, 20, 30 years. But everything has a shelf life. Everything has a, you know, we are not immortal. So, and nothing is forever. So the objective is to increase the longevity. That's actually what we are trying to do as a human being.
Yeah.
We don't want to live forever. We just want to have longevity. You know, we want to be 100 years old and still going to concert and dance.
Yeah.
And maybe in a certain point, you know, when you will be 110 years old, you say, okay, it's over. I'm going home, right? Yeah. So that's what we're trying to do, you know, and actually we've seen it. You know, you think about my mother, my father, my grandfather, they were old when I remember my grandfather, he was 45, 50 years old, and he was old. He was like, you know, tired, he was old. And look at now, people 50 years old, they looks like kids, you know, they have a lot of energy, they've changed their diet, they've changed their activity, sport and life, that you see all these, you know, if you think about Jennifer Lopez. What do you think about Jennifer Lopez? Is she old?
She's 50.
Is she old? No, I mean, you look at her and say, oh my God, she's so beautiful.
Yeah.
And you think about 60 years ago, 50 years ago, 70 years ago.
50
you look
is
at
almost dying.
Exactly.
Yeah.
You know, and that's exactly the same when we think about restoration materials. You know, we want to improve the quality of our restoration of the life of the people, but we cannot achieve immortality. So that's basically my opinion.
Thank you very much.
No problem. My pleasure.
I'm sure everyone, you know, learned a lot from this podcast.
So,
yeah. And I appreciate your opinions.
My pleasure. Thank you very much for the invitation.
Yeah. No. Yeah. Okay. Thank you.
Thanks.